Hi, I'm Dr. Donald Stater, and this is the life-saving drug Naloxone. Everyone from the Surgeon General to the CDC to the WHO thinks that it should be more available to patients at risk of overdose. Even Cousin Jimmy thinks this is a good idea. And let's be honest, Jimmy ate a few too many paint chips as a kid and really isn't the sharpest light bulb in the toolbox. But it's obvious why everyone thinks this is a good idea. It's because the stuff works. It saves lives. It's a miracle drug. People who are dying of an overdose can get a little squirty in the nose or jabby in the arm, and they come back to life. And we need naloxone now more than ever. Last year, 93,331 Americans died of an overdose. 93,331 people. That's 7,778 people a month, 255 people a day, 11 people an hour, dead, gone. Put in terms of vehicles, that's a church bus every hour, an airplane every day, and a total of 3.5 fully loaded Titanic cruise ships every month. Now I bring up the Titanic for a reason, not only because it may be the best movie of all time and defined what love should look like for an entire generation. Thank you, Leo. But because the Titanic represents one of the most famous and egregious failures to plan of all time. Of the 2,229 people on board the vessel when it sank, there were only lifeboats for 1/3 of them, which means 1,500 people perished unnecessarily because there were no lifeboats. And right now, people are dying every single day of preventable overdoses because we're not providing treatment and arming citizens with opioid use disorders with the tools they need to not die. And that brings us to the topic of today's video, the Titanic failure of naloxone distribution in this country, and the 5 steps we can take to fix how we put naloxone in the hands of the people who need it most. Now, we should begin by talking about naloxone. The scientific evidence behind naloxone is robust. It's awesome. It kicks tail. It decreases overdose deaths by 20 to 30%. When you're given by a primary care doctor to chronic pain patients, it decreases the chance they'll end up in an ER by 50%. It improves the chance that people will use their drugs more safely. It improves the chance that people seek drug treatment and recovery. It's cost effective and doesn't increase drug use. It's better tasting, less feeling, life-saving goodness. Naloxone is a no-brainer when it comes to helping address our overdose epidemic, which is even why knuckleheads like Jimmy think it's a good idea. Now, naloxone is not a new drug. In fact, 2021 marks the 60th year since Jack Fishman invented naloxone, the 50th year since it was approved to reverse overdose by the FDA, and the 25th year since harm reduction agencies decided that lay people should have access to naloxone because overdose happens in homes, not in hospitals. The problem is that naloxone dispensing in America is fragmented, unreliable, and ineffective. While all 50 states have laws pertaining to naloxone, each one is different. 24 states allow for third-party prescriptions where doctors and pharmacists can prescribe naloxone to family members. 8 states allow pharmacists to dispense naloxone without a prescription. 4 states have either passed laws or are considering laws that make naloxone co-prescribing with opioids for certain groups mandatory. And we're not even going to cover the hodgepodge of laws that provide civil, criminal, and professional liability when naloxone is prescribed or used. It's just too scatterbrained. But here is the bottom line. Policy advocates have focused a ton of attention on naloxone prescribing, and rightfully so. Clinicians like me are terrible at prescribing naloxone. For example, in 2018, when we lost 46,000 Americans to opioid overdose, only 3 medical specialties prescribed naloxone at a rate of over 10% to patients at risk of overdose. Most specialties fell below 5%. Pain medicine, a specialty that is supposed to do the best at risk mitigation for patients on high-dose opioids, prescribed naloxone to at-risk patients only 1.28% of the time. Put another way, at best we have an 88% and at worst a 99% failure rate to prescribe naloxone to those who need it. But here's the deal, and I want you to listen closely. In most cases, naloxone prescribing does not work. And while we can all agree that clinicians should do better, it's not how we're going to address the opioid overdose crisis. You may ask why, and let me tell you. Reason 1, patients are just as bad at filling naloxone as doctors are at prescribing naloxone. Chronic opioid patients' fill ranges are between 30 to 40% in most studies. For patients, after an overdose where they almost died and were seen at an ER fill their naloxone prescriptions less than 2% of the time. Reason 2, retail pharmacies are the wrong venue for patients to get naloxone. Patients often fear the stigma of going to a pharmacy and filling naloxone. If you live in a small community or town, it means outing yourself and maybe running into your friends, your family. What's your nosy Aunt Karen gonna say when she sees you walking out of the pharmacy with a prescription for Narcan? You think she's gonna keep that a secret? Remember last Thanksgiving when she told everyone about Uncle Patrick's hemorrhoids? Our family still bears the scars of that unwelcome knowledge. Moreover, patients who are uninsured or underinsured often can't afford the medication. Pharmacies are part of the answer, but they are not the answer. Reason 3, the disease of addiction obliterates the brain's ability to perform executive functions, and hence the ability of many of our patients to assess risk, plan for risk mitigation, drag themselves to a pharmacy, present a script, and wait to fill a prescription. Reason 4 is about fentanyl. The vast majority of overdose deaths in 2021 are related to illicit drugs and fentanyl. People who have opioid use disorders tied to illicits are more likely to be uninsured, underinsured, and have no primary care doctors. They access medicine through emergency departments, hospitals, and harm reduction centers, such as syringe exchange programs. We need programs based on these locations if we want to effectively address overdose deaths. We need to make every hospital and emergency department a center of naloxone distribution. And there are only 5 principles that we have to adopt to make this a reality. 1, patients with opioid use disorders, chronic pain, and acute pain have to matter. We must take the steps necessary to assure safety, prevent overdose death, and save lives through effective naloxone distribution. We spoke about why naloxone from pharmacies is ineffective, but here's the opposite side to that coin. Naloxone from hospitals has a much better track record of success. Moreover, hospitals and ERs are where patients are. In one Delaware study, it showed that 50% of patients are seen in the ER the month before a fatal overdose. That means we can intervene on 50% of patients at risk for overdose just through the ER. 2, clinicians and nurses must learn to identify patients at risk for overdose. We cannot accept a failure rate of physicians that's between 88 and 99%. Clinicians can't let people die because of ignorance, apathy, or a failure to act. We have to, as a medical system, meet our patients where they are. 3, clinicians and hospitals must commit to not prescribing naloxone, but to dispensing naloxone. Let me repeat that again because it's the most important change. We must commit to dispensing naloxone. The patient has to have the medication in their hands when they leave the hospital or emergency department. That's how we get to 100% of patients having the medication they need to save lives. That's the key. Naloxone on a hospital or pharmacy shelf does not save lives. Naloxone in the pockets and hands of patients with opioid use disorders or at risk of overdose does. Now let's get away from the bedside and talk about the greater healthcare system. 4, hospitals and emergency departments have to commit to stocking and dispensing naloxone. Take-home naloxone programs work. They work better than anything else out there. There's a hospital in almost every community across the entire country. So it's infrastructure that already exists. We can turn on the switch anytime we want and revolutionize naloxone distribution. But hospitals can't do it alone. Many hospitals bring up the fact that naloxone dispensing is not reimbursed. They bring up the fact that they can't commit to the financial burden of buying and giving away naloxone. In addition, many state pharmacy boards actively discourage hospitals from dispensing medicines, which is correct in most cases, but not for naloxone. And that brings us to our 5th and final point. Payers and regulators must reimburse hospitals for dispensing naloxone, covering the cost of the medication so that there's no excuse, no negative financial impact for hospitals that provide this service. In 2019, Colorado passed House Bill 1065, the first law of its kind in the nation to do just that. It stipulates that payers have to reimburse hospitals for naloxone given to patients, but it only covers Colorado Department of Insurance regulated plans. It doesn't cover Medicaid, it doesn't cover ERISA plans, it doesn't cover Medicare or federal plans. In short, it's not enough. We need to dream bigger and commit to more. So let's summarize. Patients matter. Clinicians and nurses have to care. We have to commit to dispensing and not prescribing. Hospitals have to stock, and payers gotta pay. Currently, naloxone take-home programs from hospitals are based on grants or charity. And we all know that grants end and charity often wavers. This is too important for us to have a charity-based system. But if we follow these 5 simple steps, we can make a naloxone distribution system that's effective, that saves lives, that's dependable, that's financially stable, and that most importantly becomes part of our normal medical care system, like it should be. Jimmy wants it. Leo wants it. Aunt Karen wants it. Uncle Patrick just wants to sit down again without agony, but that's a totally unrelated matter. We in the medical, regulatory, and political communities can come together to build a system that works. And on this Overdose Awareness Day, we can honor the 93,000 plus Americans that died last year by committing to build the system that our patients and communities not only need, but deserve. And it only takes 5 steps. This is Don Stater, signing off on behalf of the Colorado Naloxone Project. Stay safe. Overdose is preventable. Carry naloxone.